what I want to review is the objectives. Why do we need palliative care? What is it? And to show you some more examples of clinicians and payers leading change. Obviously, you've just heard a superb example of a very recent initiative from Aspire Health that I hope will scale and replicate broadly. So Senator first mentioned this concentration of risk, and this just shows a little bit more detail about this, that actually 1% of the sickest Medicare beneficiaries account for 22% of spending, and you can actually see the dollars are a bit higher than the numbers that the Senator showed. These are more current data. The 1% spend about $90,000 a year, the 5% around $41,000 a year, and the 10% about $27,000 a year, as compared to a much lower level at around $8,000 for your average, not very sick Medicare beneficiary. And what this does is create the identification of the target population who is both in need of much higher quality care, and because that is not available, ends up using 911, the emergency room, and the hospital to manage their illness. This is an actual patient of mine, Mr. and Mrs. B. They live at 92nd and York in New York City. They're real characters. You can see that Mrs. B makes all her own clothes, and she always sews a matching tie for Mr. B. This is your typical Manhattan patient. When I met him, it was 2 years ago in the emergency department at Mount Sinai. At that time, he was 88 years old with some dementia, but he came to the emergency department because of very severe back pain that was due to spinal stenosis and arthritis. He described his pain as 8 or 9 out of 10 and was taking potentially toxic doses of Tylenol, which is all his primary physician had told him to take, with no benefit. As it turned out, we got called to the emergency department, the palliative care team, by the ER attending, because this was the 4th ED visit for this couple in the prior 2 months, and you can see the reasons. Twice before for pain, weight loss and falls, and once for agitation and confusion for constipation and fecal impaction. His sole caregiver is his 83-year-old wife. Their only daughter lives in California. They are not in a doorman building, and they don't have anybody to call after hours when there's a problem. Mr. B wanted nothing to do with us. He had been in the ER and the hospital 3 times before in the prior 2 months. He was furious at his wife for calling 911, but this is what she said to us. He hates being in the hospital, but what could I do? The pain was terrible, and I couldn't reach the doctor. So this occurred on a Thursday evening at around 6:15. Mr. B was unable to get up off the toilet because of back pain, and she tried to help pull him up, and he fell on the floor, and she couldn't get him up. She called the primary care doctor, who happens to be a cardiologist, and they got a tape. And the tape said, if this is a medical emergency, hang up now and call 911. So she did exactly as the system was designed for her to do and called 911. And as she said, I called the ambulance. It was the only thing I could do. Now, let me tell you the rest of the story, because what we did on the palliative care team was prescribe really low doses of concentrated liquid oral morphine, a very aggressive bowel regimen, connect him to a house calls program very similar to what you heard described from Aspire Health that we have here at Mount Sinai, that has its own 24/7 coverage and 24/7 phone number so that patients never have to call 911 again. We also connected them to Meals on Wheels to try to reduce the cooking, shopping, cleaning burden on Mrs. B. And we connected them to a friendly visitor program that was run by their church that they hadn't been able to get to because of Mr. B's back pain. So they're basically high school students on community service hanging out with Mr. B 3 afternoons a week after school, giving Mrs. B a break. Now, that was 2 years ago. And Mr. B has not once been back to the emergency room or hospitalized, and they're doing fine. Would I have been not surprised if he had died shortly after I first met him? No, I wouldn't have been surprised. but actually here he is. They're both remaining independent in the community with the level of support I described. And that's why I want to show you this graphic. Many people believe that the costliest 5% of patients are predominantly people in the last 12 months of life. But as you see on this graphic, it's more complicated than that. And you'll be able to find detail about this graph in the about to be released new Institute of Medicine report about care at the end of life in one of the commission papers. We asked these researchers to look at the degree of overlap between being in the last 12 months of life and being in the highest cost, 5%. And actually the overlap is only 11%. That is, only 11% of the costliest 5% in retrospect turn out to have been in the last 12 months of life. About half of this group has short-term high costs from, say, an aortic valve replacement or a coronary artery bypass grafting or a bone marrow transplant, but their costs regress back down to the baseline after that year is over. That's not a group you can intervene on particularly because they're benefiting from modern medical care and recovering and going back to a decent function and quality of life. But the other half of the group, the 11% in the last 12 months of life, and the 40% who are high cost year after year after year, this is the group that benefits from targeting and screening for palliative care interventions and long-term palliative care support. And I think if you think about Mr. B, who is now getting long-term palliative care support, he's not dying, he's not hospice eligible, he's doing pretty well. There's a safety net around him that enables that to occur, most importantly that 24/7 phone access. But if you look at prognosis and look solely at prognosis as your basis for eligibility, you'd be missing people like Mr. B. So what we have is very high acute care spending in patients like Mr. B who have multiple chronic conditions, functional or cognitive impairment, frailty, and high caregiver burden because of the misaligned incentives that Senator Frist described. And people like Senator Frist and his team are doing something about this by improving access to high-quality palliative care. And I want you to look at this definition because it was developed in consultation with members of the public through public opinion polling about what to the public is valuable about palliative care. And I think the first thing that you will note is that you will not see the word death, dying, terminal, prognosis, hospice, end of life anywhere in this definition. Patients and families are not in the market for a good death. They're in the market for a good life. And what palliative care tries to do is say we got a lot of people with chronic complex illness in the United States now thanks to the successes of modern medicine. How can we make those added years worth having? And so this definition here has really become the standard definition in the field for palliative care. It's about serious illness, not terminal illness. The term advanced illness is also problematic for the public. Most people among the public see advanced illness as terminal. They are much more accepting of the term serious illness. Its goal is to provide relief from distress, practical, physical, emotional, to improve quality of life for both the patient and very, very importantly, the all-important family caregiver, and should be delivered from the point of diagnosis in a serious illness and at the same time as regular disease treatment, not as the consolation prize for when there's nothing more that we can do. And Senator Frist showed a similar slide where palliative care is delivered from the point of diagnosis at the same time as disease-directed therapy, with the nature and ratio of those two approaches to care varying depending on the timing, the specific needs of the patient and the family. But I think the key point about this slide is the titration, the dose titration. That for Mr. B, most of the time, all he has is the 24/7 access, the Meals on Wheels, and the friendly visitors, because most of the time he's stable. But the minute he is unstable, we can dose up right away, immediately, because of that 24/7 phone number, and send a clinician to the house. And that is what averts the 911 calls and the hospitalizations. So as was mentioned before, there's now a pretty substantial body of scientific evidence showing that palliative care models improve value, and the quality outcomes that improve are listed on the left, and the consequences in terms of cost reductions are listed on the right. And I think the very critical point here that I cannot reiterate enough is that you will not get the cost reduction unless you deliver better quality. So think about Mr. B. Unless there was the ability to keep him from needing to call 911, from never getting a tape that says if this is a medical emergency, call 911, the consequence would be high cost. So the great thing about palliative care programs is if they are not really high quality and delivering standardized guideline-based palliative care as the Aspire program is doing, it will not achieve the cost reduction. And so the cost reduction is an epiphenomenon of quality improvement. You already heard about this randomized controlled trial that was published in the New England Journal of Medicine, and this was office-based cancer care, palliative care, simultaneous palliative care with best cancer care at Mass General Hospital. This is the study that you saw from Kaiser, and I think the important thing to point out about this is these were patients with heart failure, COPD, and cancer who got regular Medicare home care. And you guys probably are aware that the eligibility criteria for regular Medicare home care are the patient has to both be homebound and to have a skilled need. And the minute they no longer have a skilled need, they are discharged into the open arms of their primary doctor's instruction to call 911 if there's an emergency. This huge gap between what the Certified Home Health Agency does and what hospice does is the gap that these palliative care models are trying to meet. And I think what you see here, and as was mentioned, this is Kaiser Permanente, which is a staff model, globally budgeted HMO, is that because they could see the impact on spending in all the other silos of care, they were willing to spend 3 times more money on the palliative home care because they couldn't afford not to once they looked at the downstream impact on hospital, ICU, skilled nursing facility, ERs, and doctor specialist visits. Interestingly, the New Yorker in 2013, in their innovation issue, had an article about integration of palliative care in nursing homes, which I commend to you. It's a wonderful article. And what's so fascinating about this is that all they did was shift the bias in the nursing home away from making everyone follow the same rules. Everyone has breakfast at 7 a.m., lunch at noon, dinner at 5, everyone is bathed a certain number of times a week. They shifted it 180 degrees and basically put the patient in control of their day. So if you want to sleep all day and eat peanut butter and jelly sandwiches at 3 in the morning, no problem. If one of their residents becomes agitated, the initial assumption is that it's pain rather than dementia-driven behavior. So they treat preemptively for pain when dementia patients become agitated or start screaming or moaning. And what they find is dramatic drops in turnover of staff in the nursing home and dramatic improvement in resident well-being and family satisfaction and dramatic reductions in use of the hospital. Now, in Washington, in the Beltway, there's a great deal of anxiety about talking about palliative care, and everyone knows what the reason for this is. But actually, when you ask the public, and this is, again, public opinion research that we did with Public Opinion Strategies, Bill McInturf in Washington a couple of years ago, patients and families, the public, overwhelmingly, more than 90%, say they want this kind of care when it is defined the way I showed you earlier. So here's where we are now. The typical pattern: ED, hospital, home, no support, call 911, ED, hospital, ICU, and the lucky ones get hospice usually for a week or less at the very end. But as Senator Frist pointed out, the real cutting-edge activity in our field now is in the private sector. And this is just a few examples of what creative, innovative payers across the country are doing. This is not fee-for-service Medicare that's doing this work. This is commercial payers. And here's just one example, Randy Krakauer's Compassionate Care Initiative. A couple of quotes from him. Reading case managers' notes dramatically illustrates the need for this assistance, the too common absence of such assistance, and the almost desperate gratitude this engenders. We have dedicated ourselves to providing this help. And then I love this quote from the Wall Street Journal. If there is an opportunity to impact at the intersection of quality and cost, this, meaning palliative care, is the mother lode. And here are their data. This is a focus on about 1% of their Medicare Advantage members. They had an 82% hospice election rate, an 81% drop in hospital days, an 86% drop in ICU days, very high member and family satisfaction, and the letters of appreciation to the payer, not to the doctors, but to the payer, from families are quite moving, actually, and a total cost reduction of over $12,000 per member. Highmark Blue Cross Blue Shield in Western Pennsylvania has developed a series of programs led by Judy Black, and she's quoted as saying, studies show that people with palliative care and the opportunity to discuss their treatment goals actually live longer and have a higher quality of life. This is really about a community effort. It really is about linking palliative care expertise to primary care and to community providers like nursing homes, hospices, home care agencies, aging services, Meals on Wheels, transportation. And these are Highmark's data, again, very high satisfaction, again, nearly 80% hospice election rate, roughly double the median length of stay in hospice, and marked reductions in acute care utilization. So my organization, the Center to Advance Palliative Care, actually spent a year and a half doing an environmental scan of what payers around the country are doing. This was led by our policy analyst here, Emily Warner, and a consultant, Tom Gualtieri-Reed. This toolkit is downloadable for free. It basically looks at the structure and process characteristics of palliative care programs that reliably deliver on better quality, and as a consequence of better quality, lower cost. And I encourage you to take a look at it.